Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here for our lecture on September 13th, 2017. This is our RN and Allied Health lecture with Dr. Meredith Kiesler. So before we get started, I want to go over a few things. So if you have any trouble at all, you can go ahead and email us at unccn@unc.edu. You can also call us at 919-445-1000. That might be the fastest way to reach us, and our team is standing by if you're having any technical difficulties. You can also use Poll Everywhere, and we'll talk about that in just a moment. And finally, we hope you'll check us out on the web at unccn.org. You can find us on Facebook, you can find us on Twitter, you can find us on YouTube. All right. I do want to tell you about Poll Everywhere, and if you're joining us for the first time, this is very simple to use, and this does allow you to interact with our speaker on a variety of questions that she'll be asking during the lecture and then at the very end as well. So what you need to do is you can either go in via the web, and that's just pollev.com, pollev.com/UNCCN, and then you'll see the questions and you can answer those there. Most of our participants tend to use a phone, and what you do is you'll just text to the number 22333, the letters UNCCN. So you're going to set it up going to the number 22333 with the letters UNCCN. That allows you to join. You'll get a little message back that says you've joined. Once you've done that, you're good to go. You only need to do that once today, and then you'll be able to answer the various questions. Our first question, in 2012, the World Health Organization, or WHO, estimated that what percentage of individuals with cancer worldwide will die with pain that is not controlled? And so if you thought that answer was 20%, you could go ahead and text in A. If you believe it's 30%, B. If you believe it's 50%, C. And if you believe it's 60%, D. And this is anonymous, so we encourage everyone to do this. Please, you can go ahead and do that now, and then we'll take a look at those results in real time in just a moment. All right, so our speaker is Meredith D. Kiesler, PharmD, BCOP, and CPP. Meredith Kiesler is an oncology clinical pharmacist practitioner in the Supportive Care Consult Service. She is a lecturer in hematology oncology at the UNC Eshelman School of Pharmacy and clinically precepts pharmacy students and residents. She received both her Bachelor of Science and Doctor of Pharmacy degrees from the University of North Carolina Eshelman School of Pharmacy. She completed her pharmacy practice and hematology oncology residencies at the University of North Carolina Medical Center. Her research and practice interests focus on busulfan pharmacokinetics and palliative care. Dr. Kiesler, welcome.
Thank you so much for the introduction.
Absolutely. Very glad to have you here. So looks like we've got some poll results in.
Yes, we do.
It looks like we're kind of neck and neck with 30%, 50%, and 60%. For our audience, if you haven't had a chance to answer yet, go ahead and do that, and we'll wait just a few more seconds. So what's the real answer here? Do you want to tell them now? Do you want them to wait until you go into the lecture? What would you prefer?
We'll go ahead and tell it to them. So the actual answer is C, 50%.
Okay.
So up to half of people with cancer pain are dying with uncontrolled pain. So we'll talk a lot more about that today.
All right. And your topic is management of malignant pain in the era of an opioid epidemic, which is an incredibly timely discussion. So we hear about the opioid epidemic in the news pretty much every day.
Absolutely. And it impacts our patients so much. So it's good to get some information about how to manage pain in the era of all this going on with the news hype around opioids.
Good. Well, we're looking forward to hearing more. And without further ado, I'll go ahead and turn this over to you.
Great.
So you've got the keyboard so you can move the slides there.
Right.
And here's the cursor. And thank you so much.
Thank you, Tim. Okay. By the end of today, we will have reviewed pathophysiology of pain. We'll also go over the mechanisms of opioids and non-opioid analgesics, compare and contrast characteristics of analgesics, and also their place in therapy. And I hope you'll be able to recognize some risk factors for opioid misuse, since it is so much more common. First off, what is pain? So the International Association for the Study of Pain has defined it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. But really more simply, it's whatever the patient feels it is. And as you've probably witnessed, pain is a very subjective measure, so it's important to have a trusting relationship with a patient when you are evaluating their pain and managing it. It's a big problem, so it's estimated that really upwards of 2 million patients will be diagnosed with cancer, and that was information from 2012, so we expect those numbers to only increase as time goes on. And up to 30 to 50% of these patients will experience pain at some point during their treatment. So that could be pain due to the cancer itself, that could be pain due to the treatment that we're giving them for their cancer. But really most patients will experience pain, patients with advanced cancer. And like our poll question stated, the World Health Organization estimates that up to 50% of patients with cancer will die with pain that is not well controlled. So that's really our goal as palliative care providers, is to help make sure that doesn't happen. And many of patients with cancer pain will be prescribed opioids, and they're really the mainstay of our pharmacologic therapy for pain. So that's why it's so important to talk about opioids, how to use them properly, and make sure that we're prescribing them in safe ways for the best patients. Before we get into how to treat pain or manage it, let's talk about some of the background and the physiology of pain. Before your body really recognizes that pain has occurred, a series of steps take place. The first of which is stimulation. So you have receptors that are located throughout your body. And what happens is if you, say, cut your hand or you burn yourself, it generates an action potential, and these receptors are stimulated. There's a signal from the action potential that is transmitted. It goes through the dorsal horn of your spinal cord and then up through the thalamus, and then eventually in the cortex of your brain for processing. At that point, your brain perceives that stimulus as painful, and that's when you probably pull your hand back away from the stove burner and probably may yell, say some words that maybe you shouldn't. And then your body has a natural response, which is modulation of pain. And really what that means is your body releases chemicals to help manage the pain. So your body releases exogenous opioids, also neurotransmitters such as serotonin and norepinephrine. And really all these do is they go back down to the periphery and they dampen the ability of your body to send signals back up to the brain to experience pain. So the hope is that your body is helping manage some of the pain by natural mechanisms. And as you can imagine, this is a big target for our pharmacologic therapy. So we'll talk more about that in a minute. If you're like me, you like pictures. So this really goes over similar information. You have injury that occurs to the tissue. That could be a burn, a cut, really any kind of painful stimuli that get transmitted by once an action potential is generated. That goes through the dorsal horn of the spinal cord and then up through the thalamus and into the brain. Again, your body modulates that response, sends signals back down the descending pathway, and provides neurotransmitters, serotonin, exogenous opioids, and norepinephrine to help mitigate the pain. So not all pain is the same, and it really depends on what's causing the pain as to what the patient will perceive. We, as a broad classification, we classify pain as either nociceptive or neuropathic in nature. So in terms of nociceptive pain, you can have either somatic or visceral. And with neuropathic pain, we see either centrally generated or peripherally generated. So we'll talk about that a little more.
All right, and here we have our first poll question. So which of the following words describes a neuropathic pain? And just like you did with that first question, you can go ahead and In this case, it would be A for throbbing, B for aching, C for cramping, or D for burning. And if you all you have to do once you've used Poll Everywhere once is just pick A, B, C, or D and text it to that same text that you started. Or if you're using the web, just go ahead and put that letter in on the web. So so far we're trending with burning.
So far.
And we're not sure if that reflects several or just one right now, so we'll wait a few more seconds. I should have mentioned earlier that we'll have several more questions throughout the course of the lecture, so as these come up, just go ahead and read over it, pop in your best answer, and we'll see where you stand. You want to go ahead and let them know on this one?
Sure. Well, it looks like 100% of you got the right answer, which is burning.
Okay.
So that's one of the classic descriptors for neuropathic pain. Great job.
All right.
Okay. So just to go over the nociceptive versus neuropathic pain. So nociceptive is typically related to ongoing tissue damage. So that's your cuts, your burns, things like that. Typically your pain gets better as the stimulus is resolved. And this type of pain responds particularly well to opioid therapy. Neuropathic pain, in contrast, is typically related to injury of nerves or malfunction of nerves. It can be peripherally generated, such as nerves that have been damaged from chemotherapy, or it can be centrally mediated as well. Maybe that's a tumor in the central nervous system. Neuropathic pain doesn't respond particularly well to opioids, and they are utilized sometimes in neuropathic pain, but not as often. We typically go to more of anti-neuropathic agents like gabapentin, Lyrica, antidepressants, and things like that. The most common descriptors that patients will mention to you for neuropathic pain would be numbness, burning, tingling, electric-like sensations, and even sharp pains. All right, nociceptive pain can be further classified into either somatic versus visceral pain. Somatic pain is more your superficial injuries. It can be tissue. It's usually injury to tissue. It can be your bones, joints, muscles, skin, and even soft tissues. And it's typically localized, and patients experience more of a localized pain. It's described as throbbing, aching, dull, or gnawing. Visceral pain is typically pain related to internal organs, so this is particularly common when patients have some sort of abdominal disease. Maybe they have pancreatic cancer, and it's due to really inflammation or stretching of internal organs. It can be localized or diffuse. This pain can be a little more tricky because the pain can be referred to other areas of the body, so it can sometimes be difficult to localize. Patients will describe this as deep, cramping, pressure-like. Those are the more common descriptors. And then we have malignant versus non-malignant pain. This is very important, especially in opioid prescribing these days, because a lot of the legislature subdivides patients of whether they're receiving opioids for malignant pain or non-malignant pain. Oftentimes our oncology patients are exempt from some of the legal implications and some of the newer laws surrounding opioid prescribing. Malignant pain is typically related to the cancer. It can present anywhere from weeks to months, and it's often rapidly changing in response to either their cancer growing or it shrinking because we're giving them treatment. That pain can be either related to the cancer itself, so think of if you have a solid tumor, as the tumor grows it will cause pain and can compress local structures. It can also be secondary to the treatment. So again, we've talked about neuropathic pain because of chemotherapy. It could also be due to radiation therapy. Maybe the patient had head and neck cancer, we treated them with radiation therapy and they have localized symptoms. Pain can also be non-malignant, so this is more of your chronic benign pain, and it's more complex and even more subjective for management. It often presents over years, and it has a more stable pattern. It's not usually rapidly changing. It's pretty stagnant in nature. Pain contracts are often common with this patient population, and those are utilized very commonly in chronic pain clinics, again, to add a little bit of structure and a little bit of support to hold patients more accountable for opioids. And then, the safety and efficacy of chronic opioid therapy is debatable in the non-malignant population. There's a lot more data coming out now about that. Pain can also be acute or chronic. As you can imagine, acute pain is usually quick in onset and should last for a shorter period of time. Once acute pain is prolonged or lasts at least 3 months beyond the normal duration that's expected, we can call it chronic pain. So we've gone over some of the pathophysiology. Now let's move into some of the assessment and treatment of pain. Before any medicine is started for a patient for pain, it's first really important to make sure we're assessing pain appropriately. And this is just one method. You may have heard of others, but it's a systematic approach to the assessment of pain, to making sure you're taking all factors into account before making clinical decisions for the patient. So this is the PQRSTU method. The P stands for palliating or precipitating factors. So if you were speaking to a patient, you would say, okay, what makes your pain better? What makes your pain worse? This will kind of clue you in as to ways that you can help make sure you're keeping them comfortable with the therapy that you're choosing. Q stands for the quality of pain. So what does the pain feel like? If the patient tells you they have burning pain, you may be more led to use anti-neuropathic agents. If the patient tells you they have throbbing pain or pressure-like pain, you would think maybe that's more of a nociceptive pain and we could use opioids to treat it. R stands for the region. So where does your pain hurt? And radiation. So does your pain travel to another location? Again, that may be more common if there's nerve involvement. S is the severity of pain, and I know everyone is familiar with pain scores. So we like to use the Likert scale, which is a 1 to 10 scale. So we typically ask the patient on a scale from 1 to 10, tell me how much pain you're having. If 0 is no pain and 10 is the worst pain you've ever had. You can ask that in a couple of ways. You can ask them for an average pain score. You can ask them for the best pain score that they've seen in the last week or so, or the worst pain score they've seen. And you can take all those numbers into account in figuring out whether their pain is adequately managed. T stands for temporal nature. So is there a time of day where pain hurts worse, or is there a time of day where your pain is better? Anecdotally, we found that patients tend to experience more pain as the afternoon and evening wears on, and that can be for a couple of reasons. One could be due to activity and patient becoming fatigued towards the end of the day. We've also found that there's a little bit of a protective factor from your endogenous corticosteroids that are produced, and your steroid production, your cortisol production drops off in the early afternoon, and so you lose that protective factor in terms of pain. So patients do tend to have more pain as the day wears on. And I'd say one of the more important factors is the U factor, which is the impact on you. So figuring out what about the pain is most impactful for a patient's quality of life. I had a patient who was a professional golfer, and his goal was to be able to play 18 holes of golf once a week. So we really worked with him on figuring out how can we manage your pain so you can get through 18 holes of golf, or maybe setting a more realistic goal of 9 holes of golf and starting there. So for patients, this can be the biggest factor. So getting to the heart of why it's impactful to them and what we can do to help them live a more quality-filled life. The World Health Organization has published some guidelines of pharmacologic management of pain. So according to the World Health, pain medicine should be administered by the mouth. So oral would certainly be preferred. Again, it's the safest, it's the most easy to administer at home. They also prefer that opioids are prescribed by the clock. So giving patients a fixed time interval for administering opioids. So what that means is when you give a patient a prescription for, say, oxycodone, you would have them take it every 4 hours as needed. So giving them a very fixed time interval where they could take their medicine. By the latter has to do with the World Health Organization analgesic ladder, which we'll talk about in the next slide. It's basically a systematic approach to escalating therapy to stronger opioids in a stepwise approach. For the individual is the next thing that they recommend. So all therapy for any analgesic should be individualized. So we should be taking into account patient factors such as age, medical comorbidities, allergies, renal dysfunction, hepatic dysfunction, concomitant medications. So every treatment should be individualized for each patient. And then with attention to detail, especially when opioids are concerned, we should be double checking everything that we do, making sure that we're providing clear instructions for the patients and making sure that the prescriptions that are written are clear. So here's the World Health Organization pain relief ladder that we discussed. So basically, when a patient presents with pain, they are supposed to start at the bottom of this ladder. The first step would be to use a non-opioid analgesic. That would be something such as a non-steroidal medicine like ibuprofen or naproxen or acetaminophen, plus or minus an adjuvant agent. So those would be antidepressants, maybe anti-neuropathic agents. If a patient continues to have pain despite your interventions, then you can step up to the next step, which may include an opioid for mild to moderate pain. So those opioids are medicines such as tramadol, weaker opioids, or codeine with Tylenol, or hydrocodone with acetaminophen. Again, you'd continue to consider the non-opioids and the adjunct agents as appropriate. If a patient continues to have pain, you can consider stepping up to the third step, which is usually your stronger opioids. Those are your oxycodone, hydromorphone, morphine. Again, you would consider non-opioids and adjuvants. And then the goal, of course, would be that the patient is free from pain. Now, I will caution you, as this is a great approach for a lot of patients. It's not always appropriate to start at the bottom of the ladder for your patient. As you know, there are risks for medicines that seem benign, even such as acetaminophen and NSAIDs in our oncology population, so it may not always be appropriate to start with these agents. So a lot of times what you will see in clinical practice is us starting at the second or third step in our oncology population. And you'll probably see that more in your oncology population than you will in your benign pain population. Let's dive into some of the pharmacologic options that are available. So we saw on the last slide that adjuvant agents are considered to be an option really at any step of the analgesic ladder. Note that really all of these are off-label use for pain. If you think back to the slide where we talked about the pathophysiology of pain, pain is mitigated by natural substances like serotonin and norepinephrine. And for that reason, we found that antidepressants are a really helpful medication for treating some types of pain. So you may see antidepressants such as duloxetine or venlafaxine used to treat pain. We also use anticonvulsants. Those can be used especially in a neuropathic pain population or even for headaches related to brain tumors. You'll also see local anesthetics used. We have some topical non-steroidal medications such as Voltaren or diclofenac. There's also medications such as topical lidocaine patches or lidocaine creams that you may see utilized. We also use bisphosphonates, calcitonin, and corticosteroids, typically more for bone pain, but you may see those in clinical practice. Some of our other non-opioid agents are medicines such as acetaminophen, non-steroidal medications, COX-2 selective agents, and then opioids. Let's talk a little bit about NSAIDs. These are antipyretic, analgesic, and anti-inflammatory in their activity. And again, these are best for your nociceptive types of pain, not really going to help with your neuropathic type pains. And it can take up to a week to really see the full benefit of the anti-inflammatory effects. There's really no superior NSAID from what we've seen in clinical data, as long as you prescribe the NSAIDs at equivalent dose. So we typically choose NSAIDs based on prescriber comfort and Also patient preference. Some NSAIDs you can just administer once or twice a day, and that may be more desirable for a patient. A lot of the choice of NSAID is really based on cost. So there again, there's not really a superior NSAID, so if you can choose a more cost-effective medication, that would be preferred. But as you can recognize, in an oncology population, NSAIDs can have some challenges and some side effects that we have to take seriously. Especially if a patient is on myelosuppressive chemotherapy, we have to use more caution because this can mask a fever. Also keep in mind that some of our chemotherapy agents can cause platelet dysfunction or thrombocytopenia, and so can our NSAIDs, which can put a patient at higher risk of bleeding. So as a general rule of thumb, our team typically approaches NSAIDs with more caution just because of their risk. Acetaminophen is another non-opioid option as well. It has antipyretic and analgesic activity, but no anti-inflammatory activity like the NSAIDs. This would be good for your nociceptive pain as well. And you can find this either alone or in combination products with opioids. You do have to be cautious about overdose. The acetaminophen is hidden in all kinds of OTC cough and cold products, and patients may not be aware of that. So if you have a patient that has maximum amounts of acetaminophen that they're receiving, then they get a cold and they decide to take some Dayquil, they can lead into some trouble with hepatotoxicity. So it's a good counseling point if you're ever talking with a patient who's taking Tylenol regularly for their pain, just to make sure they're aware that it is in OTC products as well. Opioid medications are the mainstay of pharmacologic therapy for oncology patients. Clinically, these are indicated for analgesia, which is what we use them the most for. They're indicated for cough and diarrhea as well. We have an old drug that we use pretty commonly, which is called tincture of opium, that is used for uncontrolled diarrhea. They can also be used for treatment of opioid addiction. You may see that more outside of the oncology population. There are a lot of different preparations that are available, again, that help with making sure we're giving patients the most convenient dosage form and the most reasonable dosage form. Oral agents are by far the most commonly prescribed opioids, and those can be prescribed either as short-acting and or long-acting medicines, which you may have seen. And we'll go over some examples of those in the next slide. Short-acting medicines are really designed to be for, I like to tell patients, right now pain. So they're used to treat acute pain. They have a relatively quick onset with usually 30 minutes to an hour, but they have a quick offset. So the duration of action is only 3 to 4 hours on average for our short-acting opioids. In contrast, long-acting opioids are more designed to give you a basal amount of opioids. They're dosed anywhere from once every 8 hours to once every 24 hours. They don't have a quick onset, so they're not a good option for acute pain, but they are longer lasting, so they provide a more steady level of opioids. Transdermal options are available as well. That's typically like our fentanyl patch. That's a fantastic option if you have a patient that is NPO or a patient that is G-tube dependent, because you bypass the oral route. Transmucosal preparations are available, and that would be your transmucosal fentanyl preparations like Acute, the fentanyl lollipops. We don't use those commonly at our institution, but you may see them out in practice. We also have parenteral options as well, which are great for patients who, again, may be NPO for whatever reason, or patients who are admitted to the hospital for acute pain management. They're much more rapid acting in onset, and that can allow you to get a patient's pain under control more quickly. Opioids exhibit their site of action on the mu-opioid receptor. So they agonize this receptor, and what that does is it stimulates central and peripheral opioid receptors. And that causes that negative feedback, so it decreases the ability of messages to reach the brain, where your brain would recognize that your body is experiencing pain. You have those same receptors in your gut, so it can also decrease the intestinal motility, and that's why most of our patients have constipation. These opioids can also cause nausea, sedation and cognitive effects, and respiratory depression. And so respiratory depression is something that we should always be concerned about, and if we are overly concerned about a patient with the potential of overdose, then we could prescribe naloxone. That's pretty readily available now for outpatients, so it's a good option for patients to keep on hand. Patients can also develop tolerance, physical dependence, and hyperalgesia, which we'll talk about shortly.
All right, time for our next question.
Yes.
Your next poll. So there are maximum dose recommendations for opioids. If you believe this is true, please give us an A. If you believe this is false, please give us a B. We're neck and neck, and well, I was going to say trending with false, but we're going back and forth. So again, there are maximum dose recommendations for opioids. Send us an A if you believe this is true. Please send us a B if you believe this is false. All right, Dr. Kiesler, what's the real answer here?
The correct answer is false.
Okay.
Yes. So there are reasonable starting points if you're starting a patient on an opioid therapy, but really there's no what we call ceiling effect for opioids. So as long as you're increasing the doses of opioids in a safe manner, there's really no maximum amount that a patient can be receiving.
Okay.
Like I have a patient who is taking oxycodone at a dose of 200 milligrams per dose.
Oh my gosh.
About every 3 hours. And for her, we've slowly worked her way to that dose, and she's comfortable, she's cognizant, she's not sedated in any way. So really no maximum dose as long as you're increasing it safely.
Gotcha. So part of that, the key to that is that gradual increase.
Exactly.
Okay. All right. Well, thank you. Thank you to our audience for responding so quickly.
Okay. There we go. All right. Now we have some opioid options that we'll discuss. So for our mild to moderate pain, so thinking back to the World Health analgesic ladder, that would be your step 2 medications. So these would be medications like hydrocodone, which is usually combined with acetaminophen, oxycodone combined with acetaminophen, or codeine. Tramadol could also be added to this list as well, as it's a weak opioid. For more severe pain, medications would be preferred to be your stronger opioids. So that would be morphine, oxycodone, hydromorphone, methadone, fentanyl, and oxymorphone. There are a ton of medications on the market currently, and new ones that are getting added pretty frequently, especially for long-acting opioids. As our manufacturers are learning with all of the legal issues coming up with opioid therapy, they're trying to figure out ways to mitigate the use or mitigate the risk of misuse by patients. So we're getting new formulations that are being created to help reduce that risk. For example, there are medications like long-acting medications where if you try to crush them to inject them, they turn into a gel that makes it impossible to inject. So similar other long-acting medicines are coming up with these novel techniques to help reduce the abuse risk. Also increases the cost, unfortunately, and for our patients that can be an even bigger issue. In terms of short-acting opioids, we have a lot of different options that are available on the market today. So morphine is really one of our older short-acting opioids. It comes as a liquid, tablets, and a concentrated liquid. The concentrated liquid is especially helpful for patients maybe who are reaching near towards the end of life and maybe not be able to swallow. You can administer it sublingually or in buccal space and it gets absorbed. Oxycodone is also a very convenient medication. It's either with or without acetaminophen. It's available as a liquid or a tablet. So again, the liquid preparation would be a great option for patients who maybe are G-tube dependent. It could be a little easier to administer. Hydrocodone and acetaminophen is also available via a tablet or a liquid. Hydromorphone is available as well. Hydromorphone is a great medicine. It usually has a little bit quicker onset than some of our other short-acting opioids. Therefore, patients have a little bit higher risk of experiencing euphoria, and that may be why patients seem to ask for that one by name more often. Oxymorphone has a short-acting preparation as well, but this one isn't really readily available in the outpatient setting as much, so I tend to not use it as much just because it's harder to find. Again, transmucosal fentanyl preparations are a nice option for certain populations. I will caution you that this is considered to be an ultra-rapid acting agent. What that means is the onset of action is within minutes. And when we're talking about a very strong and potent opioid, it can significantly increase a patient's risk of death. And for that reason, there is actually a REMS program, or like a risk program, surrounding all of these transmucosal fentanyl preparations to help protect patients and make sure we're prescribing them appropriately and make sure patients are understanding how to take them appropriately. Like I alluded to before, our institution does not have these on formulary, but they are sometimes prescribed in the outpatient setting. Something that you have to keep in mind is the prescriber and the patient both have to be enrolled in this risk program where they acknowledge that they understand the risk of using the medicines and the benefit. And the prescribers also have to go through additional training to be able to prescribe them. Moving on to our long-acting opioids, we have morphine. Again, that's one of the more common opioids that we're using. So MS-Contin is the one you've probably heard of the most, and there's another brand name that's called Cadian. The MS-Contin, or its generic, is usually the cheapest, so we typically prefer to start with this opioid option unless we have a reason not to. Oxycodone has a long-acting preparation as well. It's called OxyContin. There's also methadone. So methadone's an interesting long-acting medicine. What makes methadone long-acting is that it's intrinsically long-acting based on its pharmacologic structure. All of our other long-acting options are really pharmaceutical manipulations of medicine to make them more time-released at different points in the GI tract. So the significance of that means that because methadone is intrinsically long-acting, it's a medicine that can be crushed and administered either orally or through a G-tube, and it still remains long-acting. So it's a good option if you have a patient who's G-tube dependent who needs a long-acting opioid, because as you know, we can't crush the other long-acting opioids. Oxymorphone has had a lot of press lately because of its abuse potential, so it is being pulled from the market, but it's still available right now. Hydromorphone, hydrocodone also have long-acting preparations. And then fentanyl patch. As you may have seen, it's a patch that is where the fentanyl is absorbed transdermally, and the patch is changed every 3 days. Before prescribing opioids, it's really important to consider a lot of factors to make sure we're doing safe prescribing. First, asking the patient if they've had any allergies, if they've had any previous exposure to an opioid, and if they have a preference. Like we had a patient who refused to take morphine because that's a hospice medicine and that's for patients who are dying. And for her, she associated it with death, and we were really unable to use morphine for that patient because of her anxiety around it. We need to consider the severity and nature of the patient's cancer. Kind of think with the next steps in mind. Do we expect their cancer to get better or worse? And if so, we need to be thinking ahead and making sure we're prescribing medicines that can be titrated if appropriate. Age is also very important. With our older patients, we have to be a little more cautious with opioid prescribing. The extent of cancer also matters, particularly if there's hepatic or renal extension, because that can alter how our opioids are processed. And also comorbid disease states. And then again, the dosage form and route of administration. So can the patient take oral medications, or do they need something administered through a G-tube? Or do they need something like a transdermal patch that can be administered without the oral route? We do have to worry about development of something like tolerance. So we understand that over time tolerance can develop as patients are exposed to opioids over an extended period of time. And really what tolerance means is that a higher dose of opioid would be needed to receive the same amount of benefit over time. A physical dependence also takes place, and really that's just the body's response to removing the opioid would result in withdrawal. Where we get more concerned is if a patient experiences a psychological dependence. This is more behavioral. This is where you may see drug-seeking behavior or psychologic dependence on the medication, where they may have cravings and preoccupation with obtaining the medication. Now, there may be times where you need to switch from one opioid to another, and there are a lot of math and things that go into doing that and making that change. You may need to change because the medication isn't working anymore. Maybe the patient's having side effects. Maybe you've had a patient who's had a change in their status. So the patient's taking oral opioids at home and now they're in a pain crisis and they're on your floor as an inpatient and we need to switch them over to IV pain medicines. Or even practical considerations. Patient lost their job and lost their insurance and they can no longer afford their OxyContin and you have to switch them to a cheaper alternative. So these are some of the reasons why we may need to change from one opioid to another. Before we switch, we have to do a little bit of digging and information gathering. First of which, figuring out the cause of the pain and its history, figuring out their pain scores, and that will tell you whether their pain is well controlled or not. Looking at their concomitant disease states, again, that will help you determine which opioid therapy to switch them to. Then allergies or preferences with opioids will help you make sure you're switching to the most appropriate agent. What you do is determine the total daily usage with all of the opioids. So you total up all the long-acting opioids within 24 hours and all of the short-acting opioids within 24 hours. You lump that into one big number and you convert that to the new opioid using a conversion factor. So at UNC we have our own UNC opioid conversion guideline, and we also have one that I utilize pretty frequently through NCCN, which we'll talk about in the next slide. So you convert to that new opioid and then you individualize the dose. So we typically cut back by 25% in most cases, or maybe you want to increase by 25% because the pain is uncontrolled. At that point, you should readjust their short-acting opioid as needed, and then follow up and reassess to make sure it's working. So here is the NCCN's version of an opioid equal analgesic dosing chart. So there are a couple of different things that you can see here. So this chart will help you switch from, say you're switching from oral morphine to IV morphine. You can use this chart to switch back and forth and look at the equivalent numbers. It can also help you switch from one drug to another. So say you want to switch from oral hydromorphone to oral morphine, you can use this ratio to switch back and forth. There's also a recommendation for switching to a transdermal fentanyl preparation if that's what you're switching to. So this is a good resource for you if you're wanting to check the doses. So maybe the dose of the morphine PCA that's been ordered seems a little high. You could use this to check it to make sure it's an appropriate dose based on what the patient was taking at home with their oral regimen. So pain medicine treatment sounds easy enough, right? But oftentimes there are a lot of barriers that get in the way of us being able to provide good care for our patients. Patients are terrified of being addicted. Even though we have patients with metastatic cancer, I've had patients that refuse to take opioids because they look in the newspaper and hear how bad they are. Patients are sometimes not adherent for whatever reason, or they feel like their provider has rushed them. They don't have time to ask the questions that they need to ask. They don't feel like their pain is being managed. Providers are especially more concerned about fear of legal action. And then sometimes it's difficult to assess pain. Patients aren't the best historians in some cases. And then there's a deficiency in pain management education through our medical schools. And many times physicians are receiving little to no didactic training in opioids. So we've talked a lot about assessment and treatment of pain, but now the bigger question of how do we do all this in the era of the opioid epidemic? If you pick up the newspaper or turn on the news, you're going to see a lot of information, see press coverage over the opioid epidemic. And it has become a huge issue across the nation, especially in our state of North Carolina. And the issue is opioid-related deaths are on the rise. So a couple years ago, up to 30,000 Americans died of opioid overdose, and this was deemed to be non-heroin opioid overdoses, so just prescription opioids. An estimated 2 million Americans have a substance abuse order related to a prescription opioid. So that is a legal prescription in most cases. So someone prescribed that opioid to a patient, and either the patient misused it, a family member, a friend misused it, or it was sold or stolen or whatever that could be. So it usually starts with a legal prescription. Up to 80% of people who abuse heroin first abused prescription opioids. And then what hits home even more is in North Carolina, we've unfortunately made the news for opioid misuse. So 4 North Carolina cities are among our top cities for opioid abuse. And those are Wilmington, Hickory, Jacksonville, and Fayetteville. So who's at risk? So we can stratify based on either moderate risk or high risk of opioid misuse. For moderate risk, these are patients who have a more remote history of things like drug or alcohol abuse, addiction, but those patients have more sustained period of recovery. These patients may also have a family history of alcohol or drug abuse. Our younger patients are typically a little bit higher risk for opioid misuse. Also smokers or people with history of physical or sexual abuse, and those who hang out around people or family members that engage in drug abuse. High-risk patients are patients who have history of multiple episodes of drug or alcohol abuse, and these are usually more recent episodes. These could also be patients with a history of addiction with really no system to sustain recovery. So maybe they don't have a good support system in place, or they're still living with the same people that are abusing drugs with them. Also, patients that have a strong family history of drug or alcohol abuse, and patients with history of major psychiatric disorders. So while we can sometimes gather some of these risk factors, we should also be on the lookout for red flags of opioid misuse. We're seeing these patients in our clinics, in our hospital beds, so it's important to be on the lookout for some of these red flags. That could be early refills, requests for frequent early refills, use of multiple pharmacies, so maybe they're pharmacy hopping or doctor hopping to kind of stay off the radar. It could be obtaining multiple controlled substances from multiple providers, and we could use the controlled substances database to clue us into that. Patients may be giving or selling controlled substances to family or friends, or maybe they have a current or past abuse history with drugs or alcohol, or they're abusing marijuana. That could be a red flag for opioid abuse. Patients who are overly familiar with the street names for medications, that could be a clue as well. I had to Google what 512s were because a patient told me they wanted a refill on their 512s. Apparently that is Percocet, in case you were curious. Inconsistent results from urine screens are also a clue for opioid misuse. Also, patients who drive a long distance to obtain pain medicines from their provider. And any kind of history of drug overdose, whether that was intentional or unintentional, could be a red flag. So how do we reduce this risk? Really, we need to make sure we're prescribing for the right people and prescribing only if the benefits outweigh the risk. This can be really tough in an oncology population because we have patients who we understand have legitimate opioid needs but may be at risk for abuse. So again, this is an individualized conversation with each patient to determine if they are appropriate for even receiving opioids. You should utilize a prescription drug monitoring program, and in North Carolina this is legally changing and will be required for prescribers. So I anticipate everyone being even more familiar with this controlled substances reporting system as the year goes on because we'll all be seeing it more often. Consider urine drug screening for patients when appropriate, and trying to prescribe small amounts of opioids at short intervals. Again, less pills in a patient's hands, we hope, is less risk and less temptation. You can require the use of one pharmacy, again, to prevent some of this pharmacy shopping, and initiate a written agreement or a contract. And some of these things are utilized. Again, these are only some strategies for minimizing risk, and they're not perfect, but they can be helpful. So to conclude, many patients with cancer will experience pain at some point in their treatment. And opioids really are the mainstay of therapy, and they do a great job at treating pain and keeping people comfortable. And so many people go throughout their cancer treatment with adequately controlled pain, and they use opioids appropriately. There are people who do abuse these medicines, and people are at risk of abuse. So it's important to understand who's at risk and try to reduce that risk by using some of the risk mitigation strategies we discussed. All right.
All righty. Dr. Kiesler, thank you so much.
Thank
this
you.
is an amazing amount of information.
Oh, yeah.
And I'm sure very pertinent to our audience. Let's see, we're going to go ahead and take a look at questions. And so just a reminder, if you have questions for Dr. Kiesler, please go ahead and just, if you've already started using Poll Everywhere, just text those questions to us and we'll see them up on the screen and she can address those. I've got a few to get us started. You mentioned that a lot of patients have fears about addiction. So with considerations for the unique needs of cancer patients, how would you help to address those fears that a patient may have?
I use that as an open door to ask more questions. Mm-hmm. So why are you scared of addiction? Mm-hmm. Sometimes you find out it's because they've been addicted before. Okay. Sometimes you find out it's because their friend died of a drug overdose. Sometimes it's just because they read it on the news. And I think each of those situations opens up a different opportunity for discussion. Right. If it's your patient who had a drug relapse 5 years ago, that may lead you to treat them differently. Gotcha. And may lead you to add in some safeguards like an opioid contract, using smaller quantities of opioids, do some different monitoring strategies that maybe you wouldn't have done otherwise. Gotcha.
And that contract, you mentioned that in your summary there. What would that contract look like? And are there examples that our clinicians might be able to find on the web in terms of what what might be contained within a contract of that sort?
So we have a contract that we utilize in some situations. It's usually our higher risk patients who have been identified as high risk of opioid misuse, whether that's previous misuse or maybe it's drug-seeking behavior, and we've initiated one after the fact. Okay. Usually our contract stipulates that we are able to do random urine drug screens. Gotcha. It also requires that they inform us if they receive an opioid prescription from any other provider. It informs that we won't allow early fills of opioids. So again, a little more structure around their treatment to just decrease risk and kind of protect them from doing things, but also protecting us as well as the prescribers.
Yeah, no, that sounds like a great idea. Obviously, you can't guarantee that the patient will adhere to that, but presumably the likelihood is better if they have participated with this. Well, Absolutely. We do have some questions that have come in. Thank you for the wonderful presentation. Can you talk a bit about how you talk to patients about decreasing weaning from opioids after their cancer treatment has been completed?
Yeah, that's a tough one. A lot of that has to do with the etiology of their pain. We're seeing this a lot in our survivorship population who maybe had a taxane-related neuropathy that ended up not being responsive to non-opioid therapy, and we've had to add in opioids to help with it. What we typically do is in this situation, we are actually initiating our survivors on opioid contracts, really due to some CDC guidelines that kind of force us to treat our survivors as different as our chronic pain clinic, our chronic pain patients. So what I like to do is just kind of lay that out for them that, opioids long-term can have side effects. Opioids long-term can actually really increase their pain because patients can develop hyperalgesia. They can actually need more opioids over time. So we've tried to systematically cut back on opioids in some of our survivor population. Small, very small dose decreases over long periods of time so they don't notice a huge difference.
All right, thank you.
You're welcome.
What are some good things to say to patients to help them understand that pain management is not necessarily going to eliminate their pain, but control the pain to a tolerable level?
Yeah, that's a fantastic question. Patients can become very frustrated over this when they expect the pain medicines to completely rid them of pain. When I meet a patient, I like to ask them what their goal is for a pain level and use that as a starting point. For some patients, their goal is a 0, and they'll tell you that. For some patients, they'll start off with a goal of 3. And I think that I use that as an opportunity to say, I think 3 is a reasonable goal, and we'll work to get you there. For a patient that states that their goal is a 0 out of 10 pain score, I usually use that as an opportunity to say, while we would love to be able to get your pain completely resolved, we really need to focus on making sure you're functional, making sure you're doing the things that you enjoy, that you're sleeping well, and pain isn't interfering with your activities of daily living. And we start with that, and then if we're able to push a little harder and get their pain even better, then we can, but trying to let them know that sometimes a 0 out of 10 pain score is not always reasonable.
Okay, thank you. I have a patient who has poorly controlled pain and is nervous about becoming addicted to his medications because he has started to experience physical withdrawal symptoms. How can this fear be addressed in clinic?
Great question. Again, that kind of goes back to the definition. So sometimes patients do have that misconception that opioid withdrawal is the same thing as addiction. So I like to separate that out and explain to patients what physical dependence mean. We would anticipate that any patient who is on opioids around the clock for an extended period of time becomes physically dependent. And if you were to abruptly stop their opioids, they would experience withdrawal. That's pretty well documented. But the psychological dependence and the addiction is very different. That's more of the mental craving. That's more of the psychological craving. So I try to kind of separate those things out and explain the definitions, and that usually seems to help people understand that physical withdrawal symptoms are normal for any person on opioids, any people who are using them appropriately over an extended period of time, because your body just becomes used to them.
All right. And what about drug accounting methods for outpatients? Pill counts or diary, witnessed wastage, etc. Is this a feature of contracting?
It can be, and I know that our partners who are more in the chronic benign pain clinic utilize this for every patient. So their contract stipulates that they will do pill counts, and they do them at each visit where opioids are prescribed. Our clinic has only utilized that for a few high-risk patients. We do require diaries for some patients, but we haven't done pill counts on many patients, really due to manpower. But it is a good option, and it can be a feature that's included in a contract. Again, that holds patients accountable. It's making sure they're taking the appropriate amounts of opioids and not overusing them. Good question.
All right. Well, thank you. We should probably go ahead and wrap up. I've just got a couple of things that I want to acknowledge and mention before you leave today. We want to thank the UCRF, the University Cancer Research Fund, and the generous support of the North Carolina General Assembly for that fund. We want to thank the UNC Lineberger Comprehensive Cancer Center, and we want to thank our team, Mary King, Veneranda Oborre, and Alan Brown, for all their hard work to make these lectures possible. We want to call on you and every listener out there, and please spread the word. This is the time when we have our survey. We really rely on your feedback to create the best program possible and to create the best lectures possible and best topics. So please tell us what you think. Take the survey, www.unccn.org/2017 survey. Please go there. Please take a few minutes to fill this out. We really count on you to do this and to make our program better each year. Closing date is September 27th, so time is running out. Hope you'll do that today. Upcoming lectures. On September 22nd at noon, Medical and Surgical Oncology Lecture, Head and Neck Cancer Treatment and Complications with Dr. Janiko Grilli-Olson. Hope you'll be here for that. September 29th, our Community Lunch and Learn Lecture on Cancer, Managing Financial Toxicity When Facing Cancer with Dr. Molina and Jean Sellers and Jenny Spencer. We hope you'll be here for that. And then finally, our next RN and Allied Health lecture will be at noon on October 11th, and that's psychiatric medications. I am not a prescriber. What do I need to know with Dr. Kyle Lavin. So we hope you'll be here for all of those. Check us out on the web, unccn.org. You'll find all of our events. You'll also find our library of previous events, and all of our lectures, including this one, which will be online in about a day, are available there. Lots of other information as well. So thank you so much for being with us today. And Dr. Kiesler, thank you.
Thank you.
Really appreciate
Thanks for
your
having
talk
me.
and being here today.